morning and welcome to the San Diego Spine Foundation webinar series. I'm honored to have you guys here this morning and join our amazing faculty. I'm super excited to get going with you guys and share on a systematic approach to pediatric spine deformity care. We have four really fantastic speakers with us this morning that I'm sure will keep the sessions alive and engaged. I just wanted to draw your attention just to a few things at the bottom of your screen. If you can see that you can click on the chat section, and we highly encourage you to use that button to ask questions, even during the talks. That way we have a good head start during the discussion part to keep our speakers engaged. I guess without further ado, I wanted to take a moment also to just thank our sponsors for this meeting that have been obviously critical to be able to get this meeting off the ground. And again, sorry, a little delay in my slides. And again, thank you, Medtronic, Orthofix, and Stryker for your support of this webinar. And without further ado, we're going to get going. So I'd like to introduce to you guys Bob Cho. Bob has a very special place in my heart. He was the fellow at Rady Children's Hospital a year after I ended my fellowship. And we had a great time just early on together, even in the hospital and hanging out. He was, I thought, extraordinarily energetic and fun back in the operating room and on rounds and in our interactions then. And I think over time, he has simply gotten more and more energetic and fun to listen to. So he is currently the Chief of Staff at Shriners for Children's Medical Center in Los Angeles. He also, I think, is the Chief of Staff of the clinic in Tijuana as well. Has done some amazing work, is a really phenomenal surgeon. But maybe even better than that, a phenomenal thinker. And he's a wonderful communicator and will provide, I think, a very lively 10 minutes for us. And Bob, why don't you take it away from here? Thanks for coming.
Thanks so much, Greg. So I am honored to be here. Yeah, Greg has always been a mentor to me. He was a year ahead of me. And when he started practice in San Diego, we got to do cases together with Dr. Barney as the godfather, making sure we didn't get into too much trouble. I'd like to thank everyone on the call. So today we're going to talk about early onset scoliosis. They're all different, and can a systematic approach to this result in more predictable outcomes? These are my disclosures. None are really relevant to this talk. So the answer is yes. Can it lead to more predictable outcomes? Yes. Well, maybe. And we'll go through it. So all the cases that we get in EOS are different. So this is a 22-month-old male, and you can see this is going to be very different from this kid who's 7 years old with a history of Escobar syndrome. And then this kid who's also 7, but his Prader-Willi is quite obese, versus this kid who's 22 months old with no other medical history, versus this kid who's 20 years old. And so how are we going to treat all these differently? And so I'm going to try to have you guys go through my thought process. And so obviously we know there are many different etiologies, which means that early onset scoliosis is going to be quite challenging to treat. When I think about this, I try to think about this with respect to this classification. So this classification was put out a few years ago, and I think it's helpful. And I'll show you which parts I think are especially helpful. So it's important for us to speak the same language so that we can improve treatment. And then the important takeaway points are really the type of curve, I think, is the most important, that followed by age, and then all the other stuff: curve magnitude, amount of progression, presence of kyphosis. And so the important thing is that what works for one does make sure that it means that it may not necessarily work for another. And so when I think about it, I kind of separate congenitals versus everything else. That's partially because those congenital curves tend to have more fixed focal problems, and the other ones tend to be a little bit longer and require different solutions. So we're going to talk about this bottom half, the neuromuscular syndromic and idiopathic kids first. And so when I think about treatment strategy, I think separate them out, obviously non-surgical versus surgical. And we'll go through some of these things right now. Um, and so when we think about it, can we put these kids into a brace? There's not a ton of published literature, and there's a lot of prospective studies that are being concurrently run through multiple study groups to evaluate versus bracing versus casting. There was a recent study actually that showed uh, cast and brace treatment kind of alternating between them. You can read this in JPO in September 2020, and they got good results. But really, for any type of any type of early onset scoliosis, I think that a child's very young and flexible. I think infantile casting is really the method of choice. And the key with this type of casting, you have to have the right table, and then you have to have a mold that incorporates derotation. And you can see that being done over here. You want to get the rotation out of the spine. And when you're done, your cast should look something like this with a large belly cutout, plus or minus a cutout in the back for relief. And then you can see from Jacques Destou's paper here that if you start the casting before 2 years of age, usually it improves the curve dramatically. And then the results aren't quite as good if you initiate casting after 2 years of age. And so this is the case I showed you in the beginning. This kid started out with a 70-degree left thoracic curve, but you can see after 6 casts, changed every 2 months, this kid is just about straight. And that's what you're trying to achieve. And then what about failures? Don't necessarily think about casting as a failure. It's often just a delay tactic that gets you to eventual surgery. And if you can cast a kid long enough so that they can have a single surgery, I think that's a success. So think about it as an adjunct to your armamentarium here. And then what about growth-friendly constructs? The vector device is probably the first one that a lot of us used, or one of the early ones. This was originally under humanitarian device exemption, and subsequently it was cleared through the 510K pathway. And the clearance was for thoracic insufficiency syndrome, which is the inability of the thorax to support normal respiration or lung growth. Very nebulous definition, but off-label uses abound for this, and everyone has seen this. You can see there's a device basically that allows the spine to grow and allows the space between the ribs to grow as well. And you can see that what we're trying to do is increase the growth of the spine to allow the alveoli to fill in that space for the lungs. And you can see there are some pros. There are rib-based anchors which can help modulate that thoracic growth and the spine growth, but it can stiffen the thoracic cavity and cause autofusions. And a lot of us who've ever revised these have seen really large autofusion through the uninstrumented areas even. And it can cost a decent amount of money, and often you can see these under these skinny kids, the implant profile. So what about traditional growing rods? These are rods that incorporate rib or spine-based hooks, cephalad and pedicle screws distally. And really, a lot of people use one or the other. I think we think that the cephalad rib-based hooks may be safer and sloppier than spine-to-spine growing rods. And you can see why are the proximal rib anchors safer. There may be some pull out to the ribs and not into the canal, which is a little bit safer. And that less stable proximal anchor may allow some movement in that spinal segment, which may mean less autofusions. Woody Sankar looked at this in a paper about 10 years ago, showing that those hybrids with hooks on top and screws on the bottom had less complications than the other ones. And this is what you don't want to see. You don't want to see that those proximal implants violating the spinal canal when they fail. This thankfully isn't my case, but this is something that if you do see this, a kid can have some neurologic injury. What about the magic device? It's a 510K cleared and uses a magnetic force to distract and implant a growing rod across fixed anchors. I think we've all seen these before and we've all used them. And these really have changed our practice in that we don't have to go in every 6 to 9 months to lengthen these kids. And one of the pros is that they do go to the hospital less, so you do have a decrease in hospitalization costs if it's in there long enough, and perhaps less surgery for patients. patients with less pain with lengthening in office versus surgery. And you can increase the frequency of lengthening, which means you may be able to modulate growth a little bit better. But this implant is quite expensive. It's about the cost of probably Greg's car. And there are some unknown long-term complications with possible metallosis. And Ken Chung, he reported a 44% reoperation rate at 2 years. So it's not really a panacea. And so this is a kid who had syndromic scoliosis. You can see a long sweeping flexible curve, history of Escobar syndrome, where we put in some magic devices into him and got a reasonable amount of correction, and then we're able to grow him over time. And then as far as this kid, this is another 7-year-old kid, syndromic as well, but you can see she's very different, bigger curve. She has Prader-Willi, much more soft tissue. And I think when we put in the devices went in well, and we are lengthening her. But I want you to notice, if I had to do this over again, there's huge amount of distance between that skin and that magnet, about almost 9 centimeters. So I got to push real hard to actuate this magnet. And so you really should possibly consider, instead of a subfascial, maybe a subcuticular placement of that actuator, and then maybe use a stronger magnet to localize actuator. I actually bought a strong magnet off of Amazon just so I could localize this kid's magnets. And then, you know, is this the new hotness? You know, we've all moved over to using Magic instead of Vector 2 or a traditional growing rod. But really, I think Muharrem's here in this conference, and you can see his paper shows that Magic doesn't seem to offer any significant health-related quality of life outcomes or the overall complication rate. So perhaps it's not a panacea, but it is a pretty strong tool in our armamentarium. What about complications? We see a lot of them. Any kid with any type of device to help grow their spine over time is probably going to see a complication with an increased risk of complication with each operation and with each year. So just tell all these kids that they're probably going to have some unplanned surgeries. And then this is Woody Sankar's law of diminishing return paper, showing that the longer you leave a implant in there, the less length you're going to gain. And then what about some other growth-friendly constructs? The Shilla device, this is a device that uses kind of a floating set screw at cephalad and caudal to allow spine to grow. And you can see that the key to this operation, I think, is to try to get that apex straight. If you can fuse the apex and get it straight, then you can use those floating implants on the top and the bottom to allow the kid to grow off the top. And this is Lindsay's paper from a couple years ago, showing that maybe the distraction-based growing rods seem to have better Cobb angle improvement and T1 to S1 length, but they have more surgeries than the Shilla. So perhaps this is better for those international children where less follow-up is needed, but you still do need to follow up these kids because they do have some unplanned surgeries. And then when we can go to the congenital kids, those kids I treat a little bit differently than the other ones because they tend to have more fixed focal curves. And so we kind of go through that same paradigm. You can cast those really young kids, and I do cast these kids. I tell none of those kids it's definitive treatment, but it's probably a delay tactic. And Nick Fletcher wrote a really good article about this. Then we go through kind of our other surgical options, insight to fusion versus hemiaphysedesis versus excision, and then modulation, like we talked about. This is a long-term study showing that hemivertebra resection, really this is our standard of care for that single hemivertebra. And this long-term study showed that these kids did really, really well. No reoperations with a kind of small amount of complications. And this is what we do for that single hemivertebra, relatively easy to treat. For the younger trainees out here, excuse me, I think this is a good way to gets started into 3-column osteotomies, doing a bunch of hemivertebra, helps you understand how to mobilize the spine, how to take out bone around neural elements, and then you can kind of move on to bigger spine operations. And then what about some fusionless technologies? So if you have bigger curves, if you have kids with hemimetameric shifts, meaning congenital scoliosis, hemivertebras on either side of the spine, then perhaps you have to span it. This is Mohamed's paper showing that you can use traditional growing rods, you can use vectors. And so this is a kid that I used a bunch of different strategies on. This kid came to me with her ear on her shoulder. I did a hemiepiphysedesis on one side, and as you can see over time, we've been lengthening her with a growth type distraction-based growing rod on the one side. I thought I was really smart when I thought this up, and then I looked up in the literature that Dave and Lindsay had already written a case report about this. So, so you should read their article. It's really quite good, talking about this technique. And then this last kid, you know, this is a kid who did have a congenital scoliosis, but by the time she got to me, she was 20. So I'm sure I'm going to treat this one differently. So in a young kid with a stiff curve, I'm going to treat that with a small operation. And an older kid with a stiff curve, this kid's going to get a bigger operation. And this was a 3-column osteotomy with a VCR. And you can see that after the operation, she had a pretty good result. So improvement of her sagittal and coronal profile. And so when I think about early onset scoliosis, I go through this kind of pathway in my head. I want to separate out the congenitals versus non-congenitals. And then I want to cast or brace all the young flexible kids, and maybe even some of the stiff ones, because brace failure isn't really failure. It may be just a delay tactic. There's still a role for traditional growing rods or vectors, and keep that in your armamentarium. And remember, MAGIC, although it's a new hotness, it's not a panacea. It doesn't prevent all surgeries, like Ken Chung showed us. And really that immature, stiff focal curve, like you see in congenital scoliosis, hemivertebra, I usually treat that with a short fusion plus or minus all osteotomies, hemiepiphysedesis, or a growing rod. And then when you get a kid that's a bit older, you have to treat that kid pretty much like an adult, which is long fusion and osteotomies of choice. And thank you. That's the end of my talk.
Wonderful. Thank you so much, Bob. That was a fantastic way to kick this thing off. And maybe we can get all the panelists up on the screen and go through a few questions that we've had come through here over the last 10 minutes or so. So, hey, Bob, we have a couple questions from our audience. The first out of Brazil from Ricardo Acasio. He said cast versus surgery in the very young. Could you kind of walk us maybe through how you think about maybe say the sub 4-year-old child that has a big curve?
Yeah, so I don't really love putting implants in any kid that's less than about 2.5. If I can delay them even to like 2.5 or 3, I think then the operation for me goes a little bit easier. And part of that's because the implants in kids less than 2.5, they're really prominent. Sometimes it's hard to even get them in the pedicle because the implants are so big compared to the child. So I'll often cast those kids just to delay them. If I can cast a kid for a long time, if I'm planning on putting a distraction-based construct, I think that's better. And because you kind of have a limited timeline and a limited amount of distraction that you get out of any growing rod. And so I try to delay them as much as possible. If I can delay a kid to beyond 5, 6, 7, I think that they're going to have less surgeries overall. Their spines will be less stiff overall, and then I can get them to be about 10 or 11 when I consider a final fusion. If I can delay them even further than that, I've had kids in casts for years, and if they can't tolerate it, then I'll give them a brace for some time. And then I'd like to do one operation if I can, just a single fusion and not putting in any growth constructs if I don't have to. But sometimes you have to because the curve gets so bad.
Dave, what's your approach to casting? And I know you have a very busy casting.
Yeah, very similar to Bob. Is once you put metal into a young child's spine, you've started the clock ticking towards an autofusion. So the longer you can delay that, the better. And I really like Bob's point that if you can delay it to maybe age 9, then you could just do one final fusion and get, wonderful correction at that point in a virgin spine. So keeping metal out of the spine as long as possible is a noble goal.
Yeah, I think it's a very important point, and very little harm is done with the casting. Obviously, there's some downsides to it. We're gonna do one last question before we move on. When we're placing rib anchors, one of the questions that came through is, have you had any pleural issues with regards to pneumothorax or pleural violations?
I have not had any from just putting in the rib anchors, not for this type of issue. Now that said, could you? Of course. I mean, you're going around the ribs, so every time I put in a rib anchor, I put in some water into the area, and I make the anesthesiologist do a Valsalva to make sure we don't have any holes. I would say it's possible, but I have not seen it.
Awesome.
Yeah, I agree. I think it's very uncommon to cause a pneumothorax or a hemothorax just from a rib hook. Ribs are fantastic places to put hooks because you stay away from the spine and stop the intentional fusion.
Okay, Bob, if you don't mind maybe looking at the questions that some of the other viewers have submitted, I'll have you answer those privately offline, and we're going to keep moving on. I'd like to introduce Dr. Skaggs now. And we're about to pull up his slides.
Or could I share screen?
Oh,
I'm not sure you have my most recent version.
Oh, gotcha.
Okay,
Go
I'll do
for
that
it.
right this second.
So Dr. Skaggs is at USC and is the chief of the hospital there, and is has been someone I have watched very closely over my career. I remember coming out into practice and watching Dave present and being like, I want to be like that guy. He is so interactive, engaging. I love every single talk he's ever put together because they're always unique. And I'm really looking forward to hearing you speak this morning, Dave. Thanks so much for being here.
Thanks, Greg. And then Greg got to know me better and didn't want to be anything like me.
No way.
Okay, so we're going to be really focused right now and applying a systematic approach for complication reduction. Let's see if I can actually change the slides. So we're going to talk about pre-op, intra-op, and post-op. And a lot of this is pre-op planning. So number one, many people do this now. Commit to a plan in writing. I personally do this in a 6 a.m. on a Saturday or Sunday morning. Go over every patient's x-rays, all the notes, the readings, write something to my team. It's now about 45 people that get this weekly email. And it does a number of things. One is it makes you commit to a plan in writing. Two, it lets everybody on your team feel respected and part of the team. And three, most of the time, someone on the team has a better idea than I did, and it really ends up helping the patient. And it also forces you to plan early, allows you the opportunity to sleep on your plan, think about it, how does it feel in your gut? And many times, you're going to change your mind over the course of a couple of days. If you just do this the morning of surgery, you're not going to get the same opportunity to really weigh on this unconsciously. So some of the specific things we do in looking at an x-ray. Number one is count the number of thoracic and lumbar vertebrae. In AIS cases, 1 in 10 of them have an incorrect number of vertebrae. That is an absolute unwinnable lawsuit if you do the wrong level because you counted incorrectly. Next, there's some very basic principles. Is you never use the apex of scoliosis for an LIV. If you do that, you're going to cause problems, as we see here on the right. Similarly, you never end a fusion at the apex of the kyphosis. Now, normally people think about seeing it here on like T6, but depending where it is, it could also be at T12 or L1. If you end a fusion here, either the UIV or LIV, you can predictably have junctional kyphosis. That will be a bad outcome. Next, people love to look at the AP X-ray to try to figure out levels. If you can discipline yourself to look at the lateral X-ray first, I think you'll save yourself. I personally have had a lot more problems in my career with DJK than I have with scoliosis adding on. So Michael Vitale, Larry Lanke, and I put together our cases, and we found out that if you draw the posterior sacral vertebral line and you pick the very center of the vertebrae, and that center of the vertebrae is the lower instrumented vertebrae in front of that line, by and large, you're not going to get DJK. But if you end up picking an LIV that's posterior to that line, there's a pretty high rate of having DJK. So you have to go in front of that line. Next, the group at New York Columbia Presbyterian Hospital showed if you have an indications conference, very frequently you're going to change the plan. Hopefully it's for the better. And in their series, none of the cases were canceled, so we shouldn't be afraid of sharing this with colleagues. We should welcome colleagues' opinions. And next is creating a culture of running towards your complications, not away from them. You know, whenever we have a complication, especially early in your career, you want to vomit, you feel awful. But that's really, especially as a young surgeon, we should run there. We should learn what we can from it. And if we create this culture of learning from complications, you start seeing other people's complications over and over and over. And that's how you systematically help prevent your own. Next, I'm embarrassed to say that I used to have residents, for the first time ever, put a pedicle screw in a live patient. You know, right now in my office, I have models, and all the residents and fellows were one-on-one with me in the office. Now we use masks. Practice using a drill bit, slowly going down the pedicle, slowly putting the pedicle screw in the right place. And I think if people practice ahead of time, of course, they're going to do better in real life. And finally, for pre-op planning is a checklist. You know, Atul Gawande taught us about this, and yeah, we all get checklist fatigue, just like we get Zoom fatigue, but we hand the checklist to the families, the same one that the residents and fellows and nurses get. And I promise you, that mom or dad is not going to have checklist fatigue. They're going to make sure we don't miss anything. Interop. Now, many people think we should be kind of somehow weighing safety versus efficiency. Absolutely not. Safety always takes precedence. Many people now have shown if you have a dedicated spine team that you'll do better. Our study showed that in the typical idiopathic case, if at least 2/3 of the members were dedicated spine nurses and techs, the surgery was 34 minutes quicker, less blood loss, and way less transfusion requirements. It seemed too good to be true. We had to check these numbers a few times. Now, we also found out that if you have a really good fluoroscopy tech, you know, we have a guy named Mike. If we have Mike there, then the patient receives 40% less radiation and the surgery is faster. So once we did this study, our next job is to make 2 Mikes, you know, train another person who's dedicated to this. And I don't have any data for this, but I believe having a spine anesthesia team helps. We have one person, we call her Little Andres, Dr. Lydia Andres, Lindsay's sister. She's the, I'd say, orthopedic coordinator for the anesthesia team. And what's wonderful is anytime we have questions, we ask her, she consults with the team, and the team has a pretty systematic approach. Next is engage everyone in the OR. For example, if I say, hey, I think we're at L5 there, everyone's going to agree with me. But if I pick the most junior person and say, what level do you think we're at? Everyone's going to think about it. And engage everyone for blood pressure. You know, right now we have a screen up and everybody looks at the blood pressure. We want the blood pressure to be around 50s or 60s during dissection to minimize blood loss. But once we correct, once you hear the rod cut, boom, then all of a sudden we want the pressures up to 70s or 80s in the typical idiopathic cases to help maximize perfusion of the cord. Google did a great study where they looked at their teams and they tried to figure out what teams do the best. And it wasn't necessarily the smartest people, it was the teams where everybody felt comfortable making suggestions. They called it psychological safety. And we have to have that type of atmosphere in our OR. How do we do that? You know, traditionally the surgeons can get angry, you can, you know, kind of beat other people down and not listen to people. When I have someone new, I say, hey, I need all the help I can get. I'm someone's husband. Do it through humor, you know, do it through sincere, please help me, I make mistakes. And here's one place where I actually see a lot of mistakes made when I review cases from St. Elsewhere. Oftentimes people are still putting pedicle screws in canals. And if we do a systematic approach where we, let's see if I can actually draw here, am I good enough? One, we just look at an AP. And if the tips are crossing, we have to assume that one or both screws are in. Now, sometimes if you have really long, perfectly placed screws, they might cross and be okay. Next, rotate the machine this way, see that there is bone between the screw tip and rotate the machine the other way. Make sure you see bone between the screw and the edge. If you do that, chances are pretty good that the tip is in the right place. Next, share the load. You know, everyone has their own favorite type of metal and derotating devices. I've now moved to doing almost every case with 2 rods at once and reducers on almost every single screw. So if we're engaging every single screw with 2 rods, one can imagine that each individual screw is seeing a little bit less load, and it's now very, very uncommon for a screw to significantly plow or pull out. Share the load as much as you can. Next is derotation. You know, derotation is really helped by osteotomies, and I would say everything is really helped by osteotomies, particularly now that people are doing osteotomies with a harmonic scalpel. They can be done safely, quickly, with a lot of blood loss. And I would say, particularly in thoracolumbar curves that seem a little bit harder to derotate at times, don't hesitate to do an osteotomy, and then it takes less force to put the spine in the correct position. And at the top of your construct, wherever you're ending, whether it's T2 or T13, wherever it is, I still have Vern Toller's voice in my head saying, add a little extra kyphosis at the top that helps prevent PJK. I'm trying to do studies on this, but it's really hard to figure out exactly, you know, how much extra kyphosis is at the top. If anyone's smarter than me can tell me how to do this study, please help me. We personally have the luxury of having 2 dissecting teams. I have a fellow and a PA at the top, the scrub tech and me at the bottom. And with 2 teams, it just moves faster with less blood loss. And I think the one thing that really systemically helps is to have a dedicated PA. My PA has been with me for about 10 years, and I can't tell you how many times she picks up something I might forget. Whereas the resident or fellow who hasn't been with you so long may not pick that up so quickly. At Children's Hospital Los Angeles, we're big fans of power tools. You know, whether it's going to be putting in screws, using the drill to find the pedicle, doing osteotomies, or even a Kerrison rongeur. I think it's less force for the patient, less force for the surgeon. It protects both of us. And when we have crisis management, for example, we lose signals, I'd say the first thing we should do is repeat it back to the neuromonitoring person. I've seen a number of cases where it then becomes he said, she said, and neuromonitoring said, I told the surgeon said, no, they didn't. First thing you do is repeat back. Don't feel like a nerd. They do this in the military. They do this in fighting situations. So I'll repeat back. So you've lost lower extremity MEPs, but not upper extremity MEPs. Half the time, it seems like I may have heard something wrong. And especially in times of crisis, like if you've lost signals or the correction just doesn't look right, that's time to call in for help. The culture we have at Children's Hospital Los Angeles is if we've lost signals for a significant amount of time, meaning they don't pop back instantly, I call up one of my partners. If they can come in the OR, great. If they can't, at least on the phone, we want to run the checklist with the partner, get another person who may not be quite as emotionally involved in the case. And finally, Greg, I think it was your friend who gave us this fantastic talk at the SRS, the idea of doing a debrief. So the Blue Angels do a debrief after every show. We try to do a debrief. It's kind of hard because I unscrub and the team is still closing, but it's great for the leader to start say, what could I have done better in this case? Everybody else says, what could they have done better in this case? And then at the end, thank everyone and express, you know, we're lucky to be here and take care of kids. And finally, post-op. This is very short. We found it very helpful to have a dedicated floor with 60s to where all the spine patients are sent. We used to send them to the ICU. Problem in the ICU, the spine patient's the healthiest patient. On the floor, they're the sickest patient, and the nurses take a lot of pride of having the spine sent directly to the floor. And the other thing that helps post-op is I give every patient my cell phone, as does my PA and my nurse. And I think it really helps families to be able to text or call you immediately when there's a suspicion of a problem, rather than letting the problem get too big. So thank you. And I will now unshare my screen.
That was fantastic, Dave. That definitely didn't disappoint. Thank you so much for walking us through the pre to intra to post. Fantastic, fantastic view of what you do in your practice. a few questions that came through. Dr. Vitale out of New York asked, great talk. Obviously, the PSVL as a decision aid as well, but we are now publishing that this level can vary by as much as 2.5 vertebrae from day to day, even when patients have a standard hand position. Given this, is this a reliable pre-op tool?
Yeah, that's a great question. And not only does the sagittal vary over time, but we now have pretty good data showing that when kids stand in the Schroth position, there's an average of 6 degrees of difference of the Cobb angle. Yeah, so many times if you find you're getting a different lower instrumented vertebrae in the lateral than you are in the AP, it's probably time to repeat those x-rays. Now, especially now if we have microdose EOS imaging, I really think that Michael brings up a great point. I'm very hesitant to rely on a single x-ray for LIV these days. I don't hesitate to bring the patient back and do one more x-ray. And if there's a wide discrepancy, you could ask the patient, hey, were you standing in Schroth position? How do you feel you were standing? So thank you, Michael. I also want to say, Bob Cho, we're very lucky that he's now operating at Children's Hospital Los Angeles and bringing a lot of his experience and thoughtfulness there. Being kind of an outsider coming in, if you see anything systematic or culturally that you think works or doesn't work, please add your expertise to this conference now.
Well, I wish I could say I'm adding a lot. I actually stole a bunch from you. So one of the things that I stole from you is you send an email to every single person involved with the surgery a week before the case, and it's an email documenting kind of the history of the kid, what the plan for the operation is, the types of implants, and that way everyone has an opportunity to clarify, and so there are no surprises. So since I started working there, I use this for every case, not only at Children's, but everywhere I go. So that's something that I think everyone on this conference should do. We don't exist in a vacuum. We have a lot of people around us to help us, and sending that email out, 7 days earlier, you can mitigate problems before they happen. So I think that's been great. And obviously robust pre-op, post-op conferences, you should have the opportunity to talk to people about cases before an operation and have people change your mind. I mean, Dave and I were just talking about a case that there was a slight difference of opinion because it was a difficult case. But Dave, after we talked, he talked to a bunch of other people, and it may have changed the way he thought about that case a little bit.
Yeah, when Bob talks, I shut up and listen, ask other opinions. Yeah, if we have a difference of opinion, that means we need to look into it more.
Yeah.
Hey, Tony, in private practice, how does some of this conversation resonate with regards to teams, weekly emails, et cetera? Is that something that you can build even in a private practice setting?
I do my best to do that. I mean, I work with a PA all the time. I try to do 2 surgeon cases, especially on the more severe osteotomies and things. It is harder to build teams. I don't have a PICU at my hospital, so I have to pick my cases. I find, anesthesia gets very worried about neuromuscular cases. They don't worry about the early onset kids for whatever reason, which may be higher risk, but they worry about an easy CP case. So we have different challenges there. I think you have to know your environment. It helps to be in a location for a long time, but it's a little bit harder to build teams. I find I just can't get the inertia around there, but I can manage what I can handle safely, and I have a good sense of that at this point. So, I build in as much as I can.
Awesome. Well, we're going to move on to our next speaker. So I'd love to introduce Joe Soria to you. Joe joined our team in San Diego at the UCSD in the Department of Neurosurgery after finishing the fellowship with Dr. Lenke. He's been a wonderful addition to have in San Diego. We're honored to have him as a part of our faculty this morning and look forward to you speaking to us on enabling technologies in deformity. And once again, wanted to thank our sponsors for their active engagement and help in supporting this webinar. Thank you.
Wonderful. Thanks, Greg, and appreciate Medtronic for the opportunity. Today, they wanted me to talk to you about enabling technologies in deformity. And I work out of UC San Diego, as Greg had mentioned, and I'm an adult deformity surgeon. So I'll share some of my workflows that allow for complex reconstruction. Here are my disclosures. But these are adult cases. And so I want to just share how I utilize the O-arm and some of the navigation capabilities within my workflows, which often do incorporate freehand pedicle screw placement. I'll share a case where that I did end up placing cervical pedicle screws using the navigation device and the navigated drill guide. And so this first case is a patient who's a 67-year-old woman who came in. She had postural changes in her neck and shoulder, had a significant amount of pain that was progressive over time. I'll show her lateral and AP films, and the measurements that stood out the most were that although she had a thoracic kyphosis of 60 degrees, her cervical sagittal vertical axis was 6 centimeters. So a significant forward pitch in her neck area, and she had a T1 slope that was 40 degrees. And so for this patient, for me, my hand, this is a patient who's going to have an upper cervical to lower thoracic posterior segmental fusion with osteotomies. And so part of the case, I will start with exposure and freehand thoracic pedicle screw placement, but when it comes to the cervical pedicle screws, these are all guided intraoperatively using the O-arm. The patient is placed in a halo device, and you can see her post-op films here. But what I'll highlight is the correction here in her cervical spine. Her cervical SVA ended up changing from 6 centimeters to well within normal limits, so just 6 millimeters. And so just highlighting here a video of, on the right, we have the cervical pedicle screw placement, and really it starts by using a navigated drill guide, and that's done after the O-arm. So what I'm highlighting here is that I'll place the pedicle screws with a freehand technique, and then the O-arm, the actual CT scan comes in, and I attach a navigation device, which you can see on the right, which is placed on the C2 spinous process. And there I'm utilizing the navigated drill guide in order to cannulate the cervical pedicle, and then also a tap. Sorry, there's a bit of a delay here. And so with the exception of C2 to C7, if there's any screws that do require navigation and redirection, that's also an opportunity for the navigation instrument to redirect screws. And then so for the cervical pedicle screws, it makes this actually quite facile and improves time. So you can see here on this video that if you do have the navigated drill guide, it actually works quite well. Sorry, it's delay. And so you can see in the green, I've highlighted a box here where these are the screws that are free-handed, and if there's any redirection, we could do that after the CT scan. And then the cervical pedicle screws, which are labeled in the red square above, those are navigated using a drill. And so for other cases, like this case I've highlighted here, you could also use the Stealth Midas navigation burr for decompression. So this patient was a 62-year-old woman on the left who came in after a pedestrian versus auto accident who had progressive decline in her ambulation. And because of that, she actually had severe canal stenosis on her spinal cord, and it was all around her fusion mass and her bilateral broken rod region. And for this, the navigated drill guide came in quite handy in order to navigate and drill around the fusion mass. And so here I use the navigated drill for both decompression and also navigation of pedicle screws through the fusion mass. So in conclusion, I just want to highlight that the workflows really can be quite efficient. You can still utilize freehand navigation technique, but also use the enabling technologies to mitigate any salvage of screws which need to be redirected. You can cannulate screws in very difficult anatomical trajectories, such as cervical pedicle screws. And if there are areas of osteotomies or decompressions which are quite complicated, then this is an ideal scenario for using navigation. Thanks, everyone.
Awesome. Thanks, Joe. Appreciate you walking us through that. Tony, do you use navigation as well in your practice, or?
Well, navigation obviously requires you to have an O-arm, and my hospital still doesn't have one. So, I mean, there are other techniques. We actually bought a Globus robot, and for whatever reason, it's been difficult to train everybody or to develop some inertia around that. So for me, in part because I work in so many countries where these technologies are usually not available, I put a lot of focus on, freehand, basic principles. I would love to have those at one hospital I have. I will focus some of the more complex cases there. They do have an O-arm, but the vast majority of my cases, I do without navigation at this point. I'm looking forward to bringing it in. It's really cool, especially some of those C7 screws and things where I really struggle freehand. I would love to have some of that technology.
Dr. Ekbarnia, you've been through numerous generations of iterations of ways to put in screws. And what do you see, from what you've gleaned from the past and when you look forward? Is navigation going to be enabling for us? Is it something that all surgeons should be pushing for at their hospitals?
I think, having gone through initial trials of pedicle screw, I've always learned the free hand and never had an opportunity to use in a routine basis. And I think any technology, when you get to use it, very often, then you can probably detect what is good and when is needed. But it has to be used, not just left it for difficult cases, but you have to start and use in small or simple cases and not complicated cases, and then be able to practice that. So I think there's a good place for it. I think there's no significant difference, at least to my knowledge. I think you guys probably can tell me differently, but if someone has for a long time used freehand technique, then I have no problem with that. So I think we have to see what the more comparative studies show, but I have no problem with using the technology to make it easier and safer. That's pretty much the key.
Yeah, enabling technology, right? It should enable us to do something better. How about you, Dave or Bob? Do you guys use any type of navigation in your operating rooms to make you more efficient or more accurate?
This is my navigation right here. I'm obsessively freehand. I do think navigation is helpful. I think Joe showed some good cases where it's definitely very, very helpful. But that said, I'm a big believer in being really comfortable with anatomy and freehand. If I can't get it in kind of blindly, I'll do a little mini laminotomy. I'll open it up. I'll look for the pedicle. I'll put like a Penfield 4 or something on the inside of the canal, and then I'll kind of shoot my screw into that space. So I don't want to say I almost never need navigation, or sometimes I wish I had it, especially in a revision if the landmarks are completely gone. But most of the time you can get there without navigation. That said, as navigation becomes more prominent or popular, is it going to become standard of care? That I don't know. I mean, perhaps Dave has better ideas about that.
Yeah, I think there's no question that navigation is the future and robots are the future. No question. The only question is it here and now? We look very, very closely at our pedicle screws as we've been developing power. And in something like the last 20,000 pedicle screws, there've been no neurological injuries and not any real significant problems. And honestly, I haven't had to replace a screw out of those because it was in the wrong position. So would those patients have benefited from the extra radiation? No. The truth is also, there's times when I don't try to put in a pedicle screw, maybe it's C6 because I don't have navigation. So I think it's the future. I welcome it. I'm just not sure it's here and now for most of us.
Awesome. Well, it's going to be a good segue in a technology gap, as I'm going to introduce our next speaker, and Tony Rinella. Tony is one of the most passionate people I know. He's the president and founder of Global Spine Outreach, an organization that's near and dear to the heart even of the San Diego Spine Foundation. And we're so grateful to have Tony. Tony did his fellowship with Dr. Lenke as well. I won't say how long ago, Tony.
I'm number 20.
Tony's track record over time has been a lifelong dedication to humanitarian efforts and providing free care to kids overseas. And I always love listening to Tony because he brings a ton of enthusiasm and fun videos. And not too long ago, he was awarded the SRS Blount Humanitarian Award for his service to kids all over the world. And Tony, you have the biggest heart I know of, and I can't wait to hear what you have to say this morning about how we can apply these principles even in the setting of outreach.
Thanks so much, Greg. It's an honor to be on this panel. I'm very close to the SDSF. We share an address now. It just shows you how the two philosophies are working together. So let me see if I can advance here. Let's see.
Click on the slide, actually on the PowerPoint slide once,
Yeah.
and then you should have it.
There it goes. Okay, here are my disclosures. It's not going again. Okay, well, step one is what are your goals? You have to think of the perspective, and there's a number out there. Dr. Boakye is most famous for outreach around the world. Many of you have probably been to Ghana or worked with him. He is one of my mentors, and his model in Ghana early on was a volunteer-based system, and now he has built a freestanding campus there to help these kids. Now, that is ideal, I think, in Ghana and Africa, because the infrastructure there in many countries is not so good. He can obviously help people all year round. The problem is it's expensive to build that campus, to maintain it, and it's probably out of reach for most of us and largely unnecessary in many parts of the world. Global Spine Outreach is the short-term surgical mission model. There's many great groups that are involved with this. I would encourage you to look at the SRS website in the Global Outreach section to see that. So this is really that perspective. So on level of perspective, what are your goals? Is it to make an existing trip more safe, or you take the 10,000 foot view to make a sustainable trip, which is easier said than done? And at this phase, I'm more than 15 years into this. I'm trying to set up hub and spoke models for regional outreach infrastructures. And so this is the Global Spine Outreach vision that Greg and I are working to promote at this point. So what are the problems in scoliosis training overall? There's a widening gap between degenerative techniques and complex techniques. It's very hard to find hands-on training and real patients after fellowship. It's extremely hard. And it's hard as a teacher to assess the trainees, to see real pathology, small kids, twisted spines, to evaluate the whole situation from beginning to end, to assess the culture. How do you do it? So this is an opportunity in outreach. And if you're there over many years, you can track growth. I think that's important as well. So you can gradually advance surgeons. You don't need to feel as though you have to get them to the most advanced techniques right out of the gates. There's always severe pathology that makes everybody fulfilled and exhausted by the end of the week. It's an excellent supplement to platforms like this, and I see it as ideal continuing education for fellowship programs. I'd love to see more programs use this as one of their tools. And teaching is never so fulfilling. Here's Greg and I in Chihuahua, I believe. We haven't been back this year due to COVID, but we're anxious to get back in 2021 if the situation allows. Oh, Dr. Barnett, there you go. Outreach challenges. I'm not sure why this is in this color. Let me see if we have it on the next slide. Maintaining international surgeons over time. Many of us have switched places where we work, and they have the same issues over there. Recruiting surgeons, especially when you get into your second site or third site, if you choose to do that, it's hard to maintain that kind of energy. My whole world changed when Greg entered my life. I must say, because his energy was what is needed to move beyond the one trip in Colombia I've been at for 16 years. Early on, there was issues with neuromonitoring. They didn't really believe in it, but I find the SRS has done a great job of promoting that with a lot of regional didactic training. So that's less of an issue today. But other things you have to think about. I mean, this is in the Spanish-speaking literature. You can see the nose out of the mask. We see this commonly. It can be hard to maintain a sterile field in sometimes. If you go to a location, and even if you scout it in advance, you really don't like sit through a surgery to see what their whole platform is. It's hard to understand the post-operative care, and it's hard to make people understand that even the greatest surgeon in a insufficient system, it can be a very difficult scenario, very high complication rates. And sometimes surgeons will lower their standards in an outreach setting for whatever reason as a mental issue. Here's the World Health Organization, one of their brochures, nose out of the mask. So these are the tricky nuances that are hard to assess. Other issue, language barriers. I went to Poland, I don't speak any Polish. It was hard for me to communicate. Usually half of our teams have never been on an outreach trip before, depending on the size of the team. It's a very rigorous week, and I must say I tend to be the oldest person now by often a lot, and they have the energy, but it's harder and harder on me. We leave patients in the hospital, and some teams are concerned about that. Sometimes local politics start to speak badly about us, things it's hard to predict, even though you have such a noble goal. And the local surgeons usually want to jump to the complex procedures. Now, you've probably seen Greg present this. I made this a couple of years ago, but you know, everybody sees these SRS talks and the talks we see in webinars like this, and they want to do it, right? And often they trained. They've brought it to their home system, which may or may not be a tertiary center, and they want to dive right into what they've been trained to do or what they know is the right step. So typically, this is where we come in. We come in and say, listen, you got to go step by step. You got to build from the ground up, and we have to often put our foot on the brakes. And this is very important to make sure everybody understands that when we give them these tools, they can really cause bad outcomes if they don't understand all the nuances and restraint, that gestalt that's so hard to teach. So we do it one step at a time. You do the basic techniques. Often we can do this first trip in a location. Make sure that they commit to the indications, that they actually have the right studies. Little things like that can tell you how prepared they are in the thought process. Then a hemivertebral resection, a basic osteotomy is the next step. Work your way towards the bigger procedures, which is what tend to be featured in most of our meetings. And then, because once you leave, they're off on their own, doing all this without your guidance. This is a case in point. Greg and I actually met on this mission in Chihuahua many years ago. Again, a day I'll never forget. And the first patient in line had this. You know, she needed a vertebral column resection. We hadn't tested this. They had never done a scoliosis procedure in all of Chihuahua. These patients come from all over Mexico. You see a big thoracotomy incision and you say, wait, you can't do this. As much as they've done everything they can, they need the procedure, you have to wait to assess the system. So set expectations and define success. So we actually go in advance, we speak to the CEO. It's important to get a couple of the major stakeholders in the room because of institutional memory, things can change. You hate to have one key administrator change and the whole program fall apart. But we tell them exactly what we can do. We show them these exact slides. We can bring a team. We can bring the implants. We can supply surgeons and neuromonitoring. We can participate in fundraising. We educate, and we try to do a yearly symposium. We did this for about 6 years before COVID, and we're dying to get back to it. But what we don't do is we charge, and we don't want the patients charged for any of this. We don't charge for spinal implants. We don't lead fundraising, although we can often help with them. And we don't participate in political activism. So we tell them in advance, we need a 5-year commitment. This is what we expect out of the hospital, basically the infrastructure and everything downstream from the surgeons themselves. This is exactly what we'll do, which is what I showed with neuromonitoring and implants. And this is what we expect from, often there's a local nonprofit or the hospital itself. Patients come from all over the country. We have to keep track of them. Even if you speak the language, there are often dialects that you don't know. So you really need local people who they have access to when you're gone. So you do all this up front, and then you have a perfect new mission. But despite all of these, there's always snafus in the first 5 years that can really slow progress. You know, when the costs come up, we tell them, listen, this is our data from Colombia, and we're excited to show the 20-year data of the trip. I believe it's the longest running volunteer mission in the world. Next year, we're going to be publishing this. But you could see, we started in 2001. It took 10 years for the number of local cases happening all year to really dial up. But if they're patient, and sometimes it'll be sooner because international training is improving, you know, you can see these improvements all year round, and that's our goal. We only work in systems where they want to do this. If the local surgeons take off the second you line up, the time you get there, you know you have a trip that's probably destined to fail. At a hospital level, you know, we quote these very low complication rates, but as we all know, if these more complex cases, it happens more often, and if you do 100 cases, you're going to see these complications, and often they're expensive, or they displace somebody in an ICU. Sometimes a passion project, you know, by the time the CFO really sees what it costs, they can slam on the brakes, trip 2, 3, 4, 5, and then what do you do with these patients? So you have to balance costs versus viability. You have to look at insurance factors, things of this nature. There's many countries have universal healthcare of some form or another. And you know, we don't mind as long as the patients aren't charged. At an industry level, we run into this over and over. Often the mid-level companies are very excited to help, and then they realize they don't have an infrastructure locally. Things get trapped at the border, and company may pull out on you a week or two before. And all of this has happened to me. Ideally, you have a permanent donation, but that's hard to acquire sometimes. Medtronic has been with us for 20 years in Colombia, and they've done that, so we've been very helpful. This culture of safety we've talked about, I see it happening kind of with its own inertia in many countries now, but you know, the sign in, the timeout, the sign out, make sure you know where people are going. The World Health Organization has a lot of resources here, so you can pull this up in whatever language you need. Very helpful. But remember, you are operating in their world. They are not coming into your world. And I guarantee you take for granted all the post-surgical infrastructure you have. They keep you out of trouble. I've seen children struggle with extubation after in a recovery room, no recovery room nurse. They go home at a certain time. I mean, disasters like that can really cause trouble. Number 2 through 10 on this list can really impact a patient negatively beyond your perspective. So don't assume you showing up there means it's going to go like it does in your country. So use common sense, do bigger cases early in the week, make sure ventilators are working and available. Use 2 surgeons on big cases. Always use neuromonitoring for all these cases. And as you can see, you know, as much as you think that it may be lesser than a tertiary center in the United States, we have 3 or 4, sometimes 5 surgeons ready to come in, ready to help. We can call 5 friends. They all run into the room as they mentioned, just to come in and help. Here's Larry Linke kind of helping us out in Colombia. So often I think the care can be better than the United States. You know, get your ducks in a row right up front. Make sure you see the facilities. Talk about the local politics. Often there's a local surgeon who has a lot of energy, a lot of charisma, but you might find out there's other issues. There may be a competing residency program. There may be some other program that may get in your way politically down the road. So good to know. Talk to people. Demand regular follow-up. We have 15-year follow-up on a lot of the patients in Colombia. Don't assume if they go off to their local areas that that they're doing well. Set expectations, and we're very strict about this. We make them sign documents to whatever extent that will help us, just to make sure we are committing to 3 to 5 years, and so we demand then that they do the same thing. Otherwise, as you can see, the ducks sometimes start outrunning you. Here, trips often fail in the first 5 years, and you have to build in this evidence-based mentality right out of the gates. Other things that GSO does, and I would encourage you to be involved, we try to do symposium. We did 6 local symposia in every country we've worked in on our own. The SRS does this as well. We've been blessed with having very prominent surgeons involved. Bob has helped us, so has Greg and a number of people on the call, and I want to thank everybody who's been a part of this. But you can see we get nice turnouts. You know, Dr. Linke's helped a lot, and this really brings a lot of people. It's a more common platform for learning. GSO is also building our own database now. We found, local databases are difficult, so we built this right in from the ground up so we can track patients, do research. It has all the basics here without a lot of the complexity. It can be run in any language natively that we work in. Besides the basics, we can store the images right there. That's often a challenge. We can do this. We can actually do measurements now. We've taken out 6 decimal point accuracy because I thought that was a little too much, but we're excited about this because often, you're trying to measure it on a screen. And we built in this debrief. This is Greg's idea. We have debriefs and pre-briefs really where we can do this. We can make slides right on the program. Otherwise, it can be difficult to show these slides. And it goes up on the screen. We talk to everybody from the instrumentation rep to the anesthesia team. We all talk to everybody before and after these cases every day. We go after it and we can save all these within the database itself. Because cases like this are average there. When you see, an axial view on an x-ray, that is always a scary day. And as much as you want to do this early in the week, the patients, once they hear you're there, they start filling your week with cases like this. This is just an average case. We do more 100-degree curves than less than 100-degree. We've also built in what's in the patient at any one time, what the screws are, any issues we have. You can pull this up at any time to know what's in there, because part of the safety culture is just knowing what's in there. We've all had to dig out an operative note from some other center trying to figure out how to do a revision. Well, we have this built in. One other point, just to end this out, for all of you, especially this time of year, Amazon has Amazon Smile. You can support a nonprofit. If you could support either GSO or San Diego Spine Foundation, or pick somewhere, because they give a percentage to that local nonprofit. Everything else is the same. So if you look up just amazonsmile.com or smile.amazon.com, you can really help us out. So I just want to say thank you to everybody. All right, that's it. Thank you very much.
Thank you, Tony. We're just about the end of our time, so maybe if anyone has any last-minute questions, I'll have you guys engage in that. I think what's cool to hear here, Tony, is that there are nuances that are going to be outreach specific as they relate to maybe local politics and how that plays into caring for kids and that kind of thing. But really, a lot of the principles that you spoke about were a lot of the principles that we've even heard on this webinar on communication, which is something is a common thread now in all the talks, is how do you speak to your staff ahead of surgery, in surgery, and afterwards. I think it's probably one of the most critical pieces to safely getting through an operative event and getting the patients the optimal care. And documentation, which is another critical piece, I think, in how we do that. But even documentation ends up being right back down to
yes, and when we're through here, we'll.
So, anyways, with that, I know we're at the end of our time. I also want to thank our panelists. You guys have been amazing. Thank you for these really engaging talks. And with that, I wish you guys a blessed Saturday and an amazing Thanksgiving. Once again, thank you so much to Medtronic, Orthofix, and Stryker for your support today. And we hope to see you guys in March for our next webinar. Thank you so much.
Thanks, Greg. Hi, Bruce.
Thanks, Greg.
Thanks again.
Hi, Bruce.
Great.